I'm Professor Matthias Augustin, Professor of Dermatology and also Professor of Health Economics at the University of Hamburg in Germany. I'm actually the director of the dermatology department. It's a pleasure for me to quickly summarize what was my experience with the EADV conference in Paris in September 25. First of all, this was a huge congress with more than 20,000 participants and very many parallel sessions. Nobody could capture just a tiny part of it. My special interest, because this is my research area, was in atopic dermatitis, in psoriasis, and other chronic inflammatory diseases, but also in chronic wounds and beyond. If we start with atopic dermatitis, of course, this is something which is important to all of us, and you have surely a special interest in this. The most recent data and the most, I feel, promising molecule which has recently come into healthcare is nemolizumab, an IL-31 inhibitor. You may have followed the clinical trial program and may be aware of the fact that there have been two indications for nemolizumab, one being PN, prurigo nodularis, the other being atopic dermatitis. I participated in both programs and I was glad to see the data from this, but also long-term data that derive from the long-term extension. For example, in the Arcadia program where we participated, there were already clear and positive outcomes for the people with atopic dermatitis treated with nemo compared to just topical treatment with steroids. This short-term onset of action also was followed by new data for the long-term extension. And what I can tell you is that in AD, atopic dermatitis, but also in prurigo nodularis, there's a very good control of itch at the very early time point, even after some days, with nemolizumab compared in comparison actually to topical steroids. Given this, we were also glad to see that this very early onset of action, both on pruritus and on inflammation with the EASI score, persisted across the first and then also the second year in the follow-up study. So in other words, nemolizumab, we have a fourth biological drug for treating atopic dermatitis with a lot of power. From my clinical experience with the first 100 patients on nemo, I can tell you that even if patients have failed, have good responses for the IL-4 and IL-13 inhibitors, which is dupilumab, lebrikizumab, and tralokinumab, there's a good chance and probability that they still respond to nemolizumab with this unique mode of action. On the other hand, we have also seen compelling data on more long-term outcomes and real-world outcomes for the other biologicals, dupilumab with the longest history of data, tralo and lebri. And it's fair to say that all of the four biologics have a very strong position. And they contribute to a lot of gain in quality of life and in patient health in severe atopic dermatitis. This is what we have also shown in a poster and a lecture in large-scale data from Germany. A second option, of course, is the JAK inhibitors. There were also new data, some of which I participated in, on the use of upadacitinib, abrocitinib, and baricitinib in atopic dermatitis, again with compelling data and great number of safety data. This was one of the early concerns people had because of the FDA black box warning and warning also in Europe. But we can see that those warnings, which largely derive from data gained in rheumatoid arthritis on tofacitinib, are not transferable to atopic dermatitis and the three JAK inhibitors which have been registered. So in other words, here we have another option, and the short-term and long-term data also for the three JAK inhibitors are great. So in my country, in Germany, there's the recommendation by the current guideline that we make use of those 7 substances, 4 biologics, 3 JAK inhibitors in treating atopic dermatitis from the very first moment. So there's no need to use any other drug before if there's moderate to severe disease. Now let's move briefly to psoriasis. Of course, we have much more drugs available. We have much more experience, many more long-term data for the biologicals and other, also the small molecules in psoriasis. But nevertheless, there were coming some new recent data which show that the IL-17 and 23 blockers, for example, are very relevant also treating comorbidity. And this is not just psoriatic arthritis, but cardiovascular and metabolic comorbidity, which is a problem in Europe. So we, from very new data from the registries, that once we control the systemic inflammation with IL-17 and IL-23 blockers, we also have a higher probability of controlling these diseases, the inflammation-driven cardiovascular diseases, metabolic disease, obesity. And of course, if it comes to obesity, there was also a question, how do we deal with those drugs which control weight and lead to a weight reduction, GLP-1 drugs? And there were some more data, first data on this, showing that in some patients, they really contribute to better also clinical outcomes in terms of psoriasis, psoriatic arthritis, when patients take them and have a marked reduction in weight, which also can be done by other measures, gastric operation, or just lifestyle changes. This was another area which was really compelling to see. And the third large area in terms of chronic inflammation was HS, hidradenitis suppurativa. There, a new kind of guideline, European guideline and recommendations were issued showing that it's recommendable to start treatment in HS if there's an inflammatory component with doxycycline, rather clindamycin, but this would also be possible. But then if there's no response, to one of the three biologicals, which lead to a good control of inflammation. Nevertheless, in many of the patients, as you know, there's also the need to do surgery, which can nicely be combined with the biological treatment as well. So this, in a nutshell, is what I found interesting and exciting in terms of treating the chronic inflammatory diseases. Thank you.